tool, but not in robotics because the robot takes away all that pain. So it was developed to do complex procedure which otherwise was extremely difficult to perform with the standard laparoscopic instruments. It is pancreatic surgery is a prime example because you have to do the dissection, which has to be meticulous dissection, and you have to do very careful reconstruction, and you cannot afford to make a single mistake. If you make one mistake during a Whipple's procedure, that mistake leads to pancreatic leak, and then you're trying to catch up. So the robot certainly makes standard lap procedures a lot easier, for example, distal pancreatectomy, but when it comes to Whipple's or major dissections and vein resections and all, it really delivers. Next slide, please. But what is the evidence? So I was lucky enough to be part of a consensus meeting in Italy just a couple of months ago. And this is the status of the robotics in the UK. Nearly 1 in 4 hospitals in the UK now have a surgical robot. There are about 170 systems across the country. 160 of them are Da Vinci. There are 10 CMR systems. 10 centers do robotic heavy surgery, and I've trained 7 of them. 3 centers only at the moment doing major dissections. And these are the name of those centers. There are 25 trained surgeons in the UK now. I've trained 19 of them, alhamdulillah. So it's a great honor to be in that position. Next, please. So this was the meeting that there were 230 participants from 30 countries, and we explored all the aspects of pancreatic surgery and see what is the evidence actually. Are we doing something just for the sake of doing it, or is there any evidence behind it? So the first question was, so I've just taken some statements out of those big consensus meeting, and here they are. So based on level 1B evidence, we can now conclude that robotic distal pancreatectomy is superior to laparoscopic. It was difficult to show that robotic surgery is better than laparoscopic surgery, apart from the surgeon's comfort. So the pain of the patient's wound is now onto the surgical robots, not on my shoulders. But is there something in for the patient as well? So there's evidence now based on grade 1B that robotic distal pancreatectomy is better than laparoscopic distal because there's a less risk of conversion. We can preserve more spleen because of meticulous dissection, and there's a lower risk of blood loss. What about the PDAC? So it has been quite contentious that we should not do laparoscopic distal pancreatectomy with ductal adenocarcinoma because the risk of spread of the cancer cells. We cannot do adequate lymphadenectomy and all those things. So based on again level 2B evidence, we can now conclude that robotic distal pancreatectomy is technically and oncologically safe and equivalent to laparoscopic, and may provide oncological advantages over lymph node retrieval. So basically it is better. You can do more radical resection with the robot than with the laparoscope. And when we talk about the pancreaticoduodenectomy, Whipple's procedure, there's again 2B evidence, which is as good as going to get for the time being, I think, that it is oncologically safe and provides adequate resection and comparable overall recurrence-free survival to open. So robotic Whipple's is as good as open Whipple's, if not better. We have to take a step back and look at the things a bit more carefully. When the laparoscopic surgery started, the laparoscopic Whipple's was not as good as open Whipple's, but then it became as good as open Whipple. Robotic starting now, and starting point it is already as good as open Whipple's. That's where we start. It's going to get better than open for sure. And again, this evidence on 2B grade that for the PDAC adenocarcinoma, which was considered to be a contraindication in some places, the robot does deliver. And periampullary, again, we have 2C evidence, but that's because we did not have subgroup analysis of these papers published on the Whipple's experience. But if you can do PDAC safely, there's no doubt you can do periampullary and lower plantio safely as well. Next slide, please. Again, look at the PubMed. If you just type in robot and pancreas and hit the search button, you will see the number of publications on the PubMed. They are just coming right, left, and center. Everybody's publishing. People are publishing their experience of 500 Whipples and vein resections. And there is now evidence that robotic PJ, pancreaticoduodenostomy, is superior to open PJ because we can do fine suturing and the view is a lot better. So duct to mucosal anastomosis is better with lower stricture rate. Next slide, please. So it has all the advantages of minimally invasive surgery, small wounds, low IQ stay. So I don't send my people to HTU anymore. They all go to a normal ward, and I have had like a good outcome so far. These are two of my patients. You can see on the right patient, he had a Whipple's procedure, obviously BMI 40 plus. I did not even feel it. Did not know the patient had a high BMI, just like Amit said. You don't feel abdominal wall is not your enemy anymore. We were sitting on the console. Robot is doing all the work, and you're just doing the same surgery as you do open or in a small BMI patient. Again, this is one of my colleagues' patients. He makes a long mid-line incision. And on the right side, I did a Whipple's on this patient, and so there's not a huge difference in our center. There was some question if the robotic is expensive than open surgery. So just last week, my hospital has given a 4-year analysis of all the HPV costing in my department, and they have compared robotic versus rest of the unit. So we have 4 HPV surgeons. I do robotic, and other 3 they don't. 2 of them do not do robotic at all, and 1 does some of it. So it came out that robotic surgery is not more expensive than laparoscopic and open surgery in my hospital. I think that we're going to write up a paper on that one. So that's a very interesting finding so far. Because patients go home early and we save a lot of money on the HDU and ITU stay, and also the hospital stay is a lot lower. Complication rate, alhamdulillah, so far is better than open. Initially, the first 2 years, I was doing case selection, only trying to find out an easier case for the robotics. But now I don't have that luxury. So whatever comes to my door, I offer them open surgery. I've had only 1 conversion because patient had multiple laparotomies previously. I put in a varus but could not introduce pneumoperitoneum, so I had to convert it. But if you can introduce pneumoperitoneum, you can do almost everything robotically. It's just like doing open surgery. So I'm going to present 2 cases here. So the first case is someone who, 54 years old gentleman, BMI 33, he had a 4 centimeter neck, tail of pancreas, and he was for distal pancreatectomy. You can see the scans, it was intraparenchymal and quite a tortuous splenic artery, and the main was also intraparenchymal. So I attempted, next slide please. So I attempted so this was patient position, lying supine in a French position, legs apart, and 15 degrees head up and 5 degrees tilt to the right side. These are the port positions. So you can see at the top, we call it target anatomy, and target anatomy is the neck of pancreas. So we place 4 ports, which are, go back please, and 4 robotic ports for robotic arms, 4 of them, and then 1 assistant port for pneumoperitoneum, and also introduce a stapler or swabs or suction irrigation. These are the standard steps. These are steps you would do in open surgery anyways. Open lesser sac, dissecting inferior border, splenic vein, splenic artery, and loop all this. So these are just all the steps, exactly the steps of the open surgery deploy for the robotic surgery. So I'm going to show you 8 minutes video. So the video starts here. We are going to lift the stomach up. It's in a slow motion, but it's not working. So lift the stomach up with the left hand and open the lesser sac. On my right hand, I have a vessel sealer, which is advanced bipolar, and open the lesser sac. Then hold the stomach from the posterior wall. There's a stable view, and then this is inferior border of the pancreas. That is this point.
Blue, green.
So this is the inferior border of pancreas. So we do the upper ultrasound for almost all the cases, and just to see where the splenic artery and vein are, and where will be our line of dissection. So going below in the space with the pancreas, and this is the splenic vein comes into view. You need to stay on the pancreas because BMI was 33, but this is a male patient, and men have more visceral fat than fat in the wall of the abdomen. Ladies are a bit more forgiving, so they have fat more on the abdominal wall, but men are just a little bit more difficult. So identify the splenic vein and loop it with a Vitral. As I said yesterday, I use Michael tie because it allows me to staple or put a clamp or hemolocks. And if it is caught in the hemostatic technique, I just cut it and leave it behind. So underneath the pancreas, we just try to identify the splenic artery, which is right over there. I'm sorry, video is not running smoothly, but I'm sure you can still appreciate what we are trying to do. So this is the robotic Maryland. These are fantastic instruments. They can mimic the hands, the movements of the surgeon's hands. And then, so once I identify the splenic artery and vein from below, I go above the pancreas and dissect the superior border of pancreas, because I just need to see where my tunnel will be. So that's where tunnel is coming from. So artery and vein has been looped with vital, and then tunnel is coming from the top of the pancreas. So this is just a tape used. So we have the option to staple the pancreas, but it's quite a bulky organ at the moment. So, and I don't like to crush it because there's no perfect way of dividing the pancreas. So what I like to do is transect the pancreas if possible. So transect with hot scissors. So we have monopolar diathermy, standard setting of 4, and divide the pancreas over there. And while you're dividing, just keep an eye for the pancreatic duct if you can see it, which is a bit difficult in the distal pancreas technique, but can be appreciated if possible. So keep on dividing, and we're using air seal. Air seal has a high flow of CO2 input and also output, so it is bit of the smoke that is generated, it just goes away very, very quickly. So pancreas is divided and pancreatic duct was right over there. And so this is the splenic artery, and it was quite interparenchymal. We have to see the scans very carefully in the preoperative setting and need to know where the blood vessels are. So I knew that in this case there are 2 big blood vessels which are going into the pancreas, and then I must dissect and control them. There's no room for error in these cases. If there's a small amount of bleeding, then the view is obscured and then you can't carry on. So in this case, I saw the splenic vein was quite full. So then we thought we should clamp the splenic artery. And to confirm that it is splenic artery, we gave ICG. And while giving ICG, the liver remained green. That means it was perfused. And spleen was dark. That means we took the splenic artery in the bulldog clamp. And that immediately led to the splenic vein losing its pressure, so which is what we wanted. And so this is a loop of the splenic artery that was intraparenchymal. So we are dissecting that. You can see the endo-receipt instrument, they provide good access. So you almost forget that you have to bend the instrument. You just like driving a car. You don't remember if you have to press the clutch or the brake. And you just move the steering without knowing which way you have to go. Your brain tells you without thinking that what to do. This was quite a big branch which was holding us back and was going right into the tumor. Luckily, we found a good margin, and this splenic vein is now being dissected from. This is the line of transection, and this should be the last part because we are right at the tail.
So it's a spleen preserving?
Just spleen preserving, yes. So splenic artery is over there, all the branches have been taken down, splenic vein, and the IMB was at this area. No, I think we preserved the IMB in this case, I think. So, and then the dissection is complete by taking the tumor off from the last part of the splenic vein. And I think we just used a vessel sealer to take it off. The tumor was in this sample specimen, and that's the specimen taken off. And then we remove the bulldog clamp and give more ICG, and that confirms the spleen is now becoming green, which is all viable. There's no ischemic patch. So that's just tells us that it's all viable tissue. And then we have to manage the stump of the pancreas. So we then quite a clear anatomy of the splenic artery and vein over there. And so we identified the splenic, the pancreatic duct in this area over there. I think that meters. And then we sutured the pancreatic stump over a hemopatch, which is just any hemostatic agent. And it was quite a thick pancreas, so I had to straighten up the needle so that I can go and make one pass. So first of all, identify the duct and then suture it with 5O PDS, and then use a 3O PDS or proline, whatever is available, and then suture the pancreas. Put some hemostatic agent to watch its work, and put a drain, and that's where you can conclude the procedure. Patient did quite well, and there was no pancreatic leak. So this was splint preserving distal pancreatectomy. Now we can next slide, please. So then I had next slide, please. I had quite a celebrity patient. So this patient was OBE. He was knighted by the Queen, and this gentleman was in a wheelchair because of polio. And at the age of 60, he had accomplished a lot. He was an entrepreneur and quite a big businessman. He was BMI of 33, but he has lost some weight for coming to me. He was found to have 3.8 centimeters. Can you just play the video? They should play. No, okay, go back, please. So he had a IPMN head of pancreas and had a strong family history of pancreatic cancer. So he wanted robotic surgery. So he came looking for me, and then we offered him robotics. Go to the next slide, please. And these are standard set of the robotic Whipple's procedure. You do the initial dissection, duodenal localization, and all that. But the obviously long procedure takes like 6 hours plus. Next slide, please. So I'm just going to show you these 4 steps in a 8 minutes video. Just before starting, so this is just to orientate ourselves. This is the neck of the pancreas. That's the SMV, and we have done lots of work. Obviously, all have been dissected, and now we are making a tunnel behind the neck of the pancreas over there, over the SMV. And these small, and then divide the pancreas with scissors. While you're dividing, you just need to look for the pancreatic duct in, because this was IPMN. No endoscopy previously, obviously the duct was 1 millimeter. So it is difficult to identify this duct because where is it? Couldn't see it. So we have to be careful, and because if you can't find the duct, that you can't do the anastomosis. So we spent some time after dividing the pancreas with hot scissors, and we found the duct just in this area. And this is a 4 French feeding tube that we placed so that your duct is secure. I tend to use a 4 French feeding tube, pediatric feeding tube. This is the IPM head of pancreas. So I do cauterization and tries mostly on the right side in the anatomical duodenal window, and bring it out. And that's when we can do the dissection. This is the SM, IVC and gonadal vein. It was a big stuck over there for some reason. Don't know why, but it was a bit stuck. And you can see the SM is the jejunal branches. So this is the IPDV, inferior pancreatico-duodenal vein that we have dissected, and then we'll slope it. So I've taken this vein with hemolock, with some clips or suture and ties, but it doesn't give a satisfactory closure because it's a bit of a white mouth or ostium draining into the vein, and it causes a bit of a crunching or crumbling of the vein. And once the hemolock slipped off, so since then I'm now using stapler for a larger veins. I know some people just use a advanced bipolar ligashore or synchroseal or vessel sealer for this vein and don't clip it. I don't feel comfortable just take it with advanced bipolar, although it should be able to, because that's what the instrument is licensed for. So then we dissect further on the uncinate and we find the inferior pancreatoduodenal artery. So this dissection is very meticulous. You have to be right onto the SMA, almost periadventitial. This one is not periadventitial, but you just have to be that close to the SMA. And to do that, you have to dissect the SMV, which is over there, and the portal vein, and you have to roll it at least 270 degrees. So, this is the uncinate. So this patient also had a replaced right hepatic artery, which is right over there. So right hepatic artery, as we know, comes of the celiac, common hepatic, right and the left hepatic, but this was coming from the SMA. It was coming from the splenomesenteric artery. So to stay right close to the artery, we did some of the work from top and some of the work from below. And now I'm working on the right hepatic artery, and we will see that it dips into the groove and comes off from the SMA. And this is the last part of the transaction. So specimen is not transacted, and I think we got about like 20 odd lymph nodes for this patient. So it was for benign resection. It was not a cancer. So IPMN is pre-cancerous, and that's what, you can see a great view of IVC, right hepatic artery, and the portal vein. So once the specimen is extracted, we bring the jejunum through the anatomical duodenal window and do a classical Blumgard pancreaticojejunostomy. So the stitch is taken through and through the pancreas, and then corner stitch. I use 3-operoline because it is a bigger needle. I use about 20 centimeter, and then we put a knot onto the pancreas, and then use bulldogs to secure the suture because otherwise they get tangled. So we apply about 4 stitches, 4 to 5, 2 to 3 above, and 2 usually below the pancreatic duct. So this stent is quite useful because you can't take a suture through the pancreatic duct by mistake. The stent is there, so it will stop you from going through it. So once the posterior layer is done, we tie all the sutures onto the pancreas over there, and use this stent, which is a simple feeding tube, 4 French feeding tube, and then use 5-0 PDS to do a duct to mucosa pancreaticojejunostomy. This 1 millimeter duct, and it's easier to tackle robotically. Laparoscopically, it's just very, very difficult. Open, you have to use the loops because, and then when you're growing older, like I'm every year I'm 1 year older, obviously, and as everybody else is. But when your eyesight starts to give up, when your prostate starts to become a bit bigger, you just feel tired at this part of the operation. So if you're doing a 6-hour long operation, when you're in your 60s, you're a bit tired doing this part of the operation. And which is the most crucial part because every stitch over here is worth £1 million. One stitch leads to a leak, and that leak can lead to lots of complications. And obviously, if somebody has a pancreatic leak, there's a risk of mortality significant over there. If there's no leak, then it's a quicker recovery. So with the robot, it enables us to do these cases in a very controlled and effective manner. Great view. If you have a bit of a hand tremors, the robot will filter those out. So the suturing is just a gift. So we've done the duct to mucosa anastomosis, and now we're doing the anterior layer and doing a bit of overlapping of the jejunum onto the pancreas, and the anastomosis is done in a controlled manner. There's no, so the view is stable. So I don't have to ask my assistant to show me this, show me that. It's just a very stable view. I've got full control of the instruments and the view, and so it is a very straightforward, pleasant experience, I must say. And then the bile duct, a very, very small bile duct, with about 3 millimeters bile duct. We measured it. So this instrument, the tip of this instrument is 4 millimeters, and this bile duct you can see is smaller than the tip of this instrument. So it was about 3 millimeters bile duct. So we did a interrupted, again, a Blumgard parachuting technique. So we did the posterior layer first of all. Did the place a suture at 9 o'clock and 3 o'clock position. Did not tie them because if you tie them, then it will become quite a small duct to tackle. And as our colleagues from India were saying, the hepaticojejunostomy is a lot better than doing it open because you can do very precise dissection. The view is amazing. You can almost see inside the hepatic duct, and you can see the bifurcation of the duct as well. You can see right and left hepatic duct just through this camera. So we place, it was only a place, enough place to apply 2 sutures posteriorly and 2 anteriorly and 2 corner, and just with these 8 stitches we did the hepaticojejunostomy. Patient did well, and there was no leak, and he went home without any complications. Next slide, please. Next slide, please. So I just wanted to touch base just a couple of minutes on HBB training pathway. It is important, as I was saying yesterday, next slide please, to learn robotic properly, because it requires unique skills which are different from laparoscopic or open surgery. Because surgeon is working away from the console, the view can be, your vision can be quite tunnel. You could be in that space and you'll be very, very comfortable over there. And you may not be aware of your surroundings, especially inside the abdomen. And you can cause some unseen damage because the instrument is not within your view. And there's no haptic feedback, so you need to learn that by training. Communication can be challenging. We are not able to communicate the way we communicate while on the patient. Just like give me that instrument, give me this instrument. You have to just say which instrument and which arm of the robot. And there are not many instruments in the robotic inventory. So, but all these things can you can overcome by training. So we published this paper, and this is now become the guidelines for the UK and abroad, and everybody just gives a reference to this. So this was the leading article in HBB journal, and I just made it up. I introduced a step-up technique, a step-up way of learning the robotics. So, so mostly for HBB, we divided the case, variety of cases into 3 categories, level 1, 2, and 3. Level 1 are cholecystectomy, liver cyst, and CVD exploration, simple cases that we do laparoscopically every day. And these are the cases that experienced surgeons can do with their eyes closed, but not eyes closed, but with one hand or something like that. So these are very, very simple cases. You don't even have to use your high mental level. So these cases should be done to learn the robot. There's no advantage for the patient or for anybody else. It's costly, but you need to do these cases to learn the robot. Once you have done these cases, then you move on to the more complex cases like gastrojejunostomy, non-anatomical resections, atypical resections, radical cholecystectomy, when you have to take a bit of a liver parenchyma and some lymph node dissections, distal penetrating spleen and all that. So these cases are level 2, when many of us are doing these cases laparoscopically already. So you are transferring your laparoscopic practice over to robotic. So stage 1, learn the robot. Stage 2, transfer your existing practice into the robotics. And stage 3 is to do the complex cases like Whippers, total pancreatectomy, major right and left hepatectomy and all that. And when you follow this regime, I've now started 9 programs and about 19 surgeons we have trained. And they have all followed this pathway. And so far we have had 0 robot-related injuries, we have 0 conversions, and 0 robot-related complications. And we've done over 100 cases so far between like 19 surgeons. So this is just a pathway after doing all the training and everything. So you can, there's a reference on the screen that you can use that paper to start your robotic program. So that's my final slide. So robotics is the future of surgery. And for the patients and for the surgeons who have this facility, they are lucky. So, welcome you guys to the future of surgery, which is you have the robot. Major dissections are feasible, safe, with at least comparable, if not better, than open surgery. And robotics will add many years to the many years to the practice of a HBB surgeon. So as I said yesterday, many of the surgeons in the UK who are doing laparoscopic Whippers, laparoscopic major hepatectomy, they have given up because they are a bit older. They can't be bothered because it's too tiring. Their neck and muscles and shoulder muscles are not strong enough. But with the robot, you can just keep going and going and all that. And thank you very much.
I think we are behind on the the schedule, so we'll have to skip the questions this time. And I would like to Dr. Sohail to announce the next speaker.
I think Dr. Rehana was missed yesterday, so she's here. Would she like to present if we have the time?
I mean, it's up to yourself whoever wants to go first. I mean, yeah. So,
मैडम के से सुनने के लिए हम आपका लेक्चर
सुन ले मैडम आपका
आज
Ajay.
और दौड़ के आए मैं कब मिस ना होते
please,
I'll
go
talk
ahead.
on robotics in gynae procedures.
Thank you so much. It is since morning, since yesterday that I have been listening to the speakers and looking at the videos. It is really intimidating where we are, and it is overwhelming that to see what is happening in the world. But it is good that we're only 15 years behind, not lucky. So Alhamdulillah, so we have started it. robots in gynae are in really infancy. Over here we have taken the first baby step. खिलाएंगे please? Yeah, आपको दे दिया था?
We transfer कर रहे हैं.
Okay, that's fine. Acha. So, just going on, that robotics in gynae is still, robotics itself is evolving, and robotics in gynae is evolving as well. Because laparoscopy has taken over in the last 20, 25, 30 years, and the transition is very gradual. I think because the facility of robotic surgery is available in very limited institutions. Where it is being practiced, and it is mostly where the Da Vinci was initially started. In states, I have seen that a lot of gynecological surgery has been done. And my talk presentation today is basically going to be, I'm just going to briefly highlight what most of the speakers have highlighted about the benefits which the technological advances is in robots, and as well as an ergonomic facility which it has provided. And briefly touching that, I think I have emphasized on the critical appraisal of gynecological surgical processes, whether we are benefiting from the robotic surgery or not. So my talk is going to be very brief, since I'm not talking to a gynecologist audience mainly, so I'm not going to emphasize on the procedures. हो गया?
Heavy file है. आपने लगता है बड़ी वीडियोस डाली हैं.
माइक ऑन कर.
मैं काफी ठीक ही बोल रही थी.
नहीं आप ऊंचा बोल रही लेकिन ये कि हेलो हेलो.
हैवी वीडियोस नहीं है, सिर्फ छोटी छोटी चीज़ें जो कि हमने हाईलाइट इसलिए करनी है कि गायनी इन द पाकिस्तान recently we have formed robotic society for Pakistan, and I really put up a little bit of resistance when I was not mentioned, gynecology was not mentioned there, and I put in my name, though I think in Pakistan at the moment only 2 centers are conducting gynecological surgeries. One is both in the private sector. One is National Hospital in Karachi, and the other is we have the privilege of having the robot here in Lahore. And in total, we have performed about 50 gynecological surgeries, roughly I think 60, 38 in Lahore and 22 in Karachi. So I think this is the first baby step. We do not know a lot about how it is translating into patient comfort, but looking at it qualitatively, it seems that yes, the benefits are definitely there. मैं तुम्हें 2 घंटे पहले
मैडम वो चल रहा था ना सेशन.
अच्छा ठीक, कोई बात. So robotics have had the advantage of giving better vision. 3D vision is available, so the tissue perception, better dissections, all this should translate into better outcomes and lesser complications in the patients, both intraoperatively and postoperatively. For me to say whether it has happened personally, it is very difficult. As I've already told you, a number of cases are rather limited, but quantitatively we have not analyzed it, but qualitatively it seems that most of the patients have benefited in the sense that they were happy to go home on the 2nd or the 3rd post-op day. A few have had post-operative fevers, wound infections were there, and I've had one patient who has had an hernia. She's recently reported that she has had a hernia from the port which we inserted, the camera port. That was, she had another post-operatively, she had pneumonia, and for that she was admitted in the hospital for a very, very long time. Ultimately, she did recover. But when we talk, when I think about the surgery, there were no problems, there were no infections, and she did not have any pelvic problems regarding that. So the second point for robotic surgery is that the tremor filtration occurs. Your own hand is not working, so even if you're faltering at any point, the robotic arm is very stable, and therefore that filtration also helps in less morbidity for the patient, that you are unlikely to create intraoperative complication like cutting the wrong vessel or cutting the wrong tissue. The third is that the estimated blood losses are also less. And all this is contributing towards that the patient is going to have less morbidity, quicker recovery.
We have the slides.
Generally, the slides, the second slide. So the first slide was showing us when we went to Dubai for our training, and we were working at the console over there, and the other gynecologist is sitting with me, who was with us. Slide. Okay, so I briefly touched the panoramic vision and the tremor filtration, and the third very important is the elimination of the fulcrum effect. The joint-wristed instrumentation facilitates us to move through 720 degrees, and that is very important. I think Dr. Jawad was already highlighting that aspect. Ugly slide. So this should have improved surgical performance, 100% honi chahiye, minimizes the blood loss, minimizes intra and post-operative complications, and the most important is reducing the need to revert to open surgery. We know at times that when we are doing minimally invasive surgeries laparoscopically, there would be incidences where we have to decide, now it is time enough, we have to revert to an open surgery. But with robotic surgery, it is important that we have seen, the literature has shown us, that need to revert to open surgery has been minimized. Ugly slide. Surgeons benefit, everybody has talked, especially the people who have to work for 6-8 hours long at a surgery, they know that these benefits are definitely there. But the most important one for the surgeon is the short learning curve. I mean, even if you are not a laparoscopic surgeon, it becomes, you learn to use both hands, and the studies have shown that 50 to 100 cases, once you have done, you are quite good at it, actually performing these procedures. The most important question comes the cost effectiveness. As I was telling my colleagues earlier, that I think we should form a pressure group regarding this, that the companies, the manufacturers are benefiting from getting the robots into the first, second, third, fourth generations, and we are the laborers who are providing them the information. We are the ones who are giving them the data from which they are getting better and better, and they are the ones who are earning. We are just working without any wages or any, in fact, we are paying them for training, letting us use the robot. So I think that is an important thing which has come to my mind at this stage, and not only the Pakistan Society over here of robots, I think in India too, we were talking earlier to the doctor who said that they are also paying about 150,000 Indian rupees to the companies for each case. So this is an important point which I think we should make, because we are helping them evolve the robot better and better, and therefore they should be paying us, in fact. So longer surgical hours are there. Designated rooms have to be given for robotic surgery. And, but all this, does it really, as you were putting it, for your open surgeries, when there are reduced number of open surgeries, less conversion rates, less time for the patient to spend in the hospitals, so it doesn't translate into the cost benefit in the long term, because now the patients are going to stay less here, they're going, even for the patients. So these studies have still to be conducted to really show that that benefit is there. Agree? Now, marketing in Pakistan, when we started the robot, I remember everybody was saying, "Apne patients ko clinic mein batao, kaho कि जी आप robotic surgery कराएं, बहुत अच्छी है." So this remains controversial as far as a professional I am concerned, because what we are marketing is the images and the text which is provided by the manufacturers. So it is a bit biased. And not only that, when we tell them at this stage, when I am going to tell my patient that you are going to have less pain, you are going to have less blood loss, less chances that you are going to be blood transfusion has to be given to you at a shorter stay, some of these things are just qualitative. So I think smart studies are required before we really are convinced ourselves. When we are convinced ourselves, then we can convince our patients in a better form. So this was a study which was conducted in US, in which they were, what was the patient, from where did the patient perceive whether a robotic surgery is good or not. And if you look at the physician counseling, patients who really responded to was only 12%. Majority of them had internet-derived information or from the print or TV, radio, media, but most of them was from the patient to patient or from friends. They heard that such a thing has happened and they would come for that. So I think our role for really disseminating this information, how good a robot would be or convincing the patient, would be limited to some extent, because it will always be suspicious for the patient. Agla? Trends in robotic utilization, I think I don't have to say, they are skyrocketing, I think, as far as the recent data shows. But where the robots were available, the open surgeries went down and the robotic surgeries went up. Ugly slide. So this is very important. When we are starting here, we need to have a standardized and validated stepwise robotic assisted gynae surgery curriculum. This should involve not only the dry lab, wet tissue labs, complex anatomy reviews, and the most important which comes is the peer-to-peer review. Because when, as a team, we are going to, there are very few people who are going to be utilizing it. And unless we go through a standardized gynecological surgical curriculum, the benefit translating for the patient is also going to be less. Isolated islands cannot be formed in which we can just do it ourselves and that is it. It has to be, teams have to work. And not only that, for example, I have the advantage that I've got great support from my surgical colleagues. So wherever, if I am stuck, they would always be there. So I don't know how many institutions would have that, but I think at the end of the day, we keep having meetings, and that is another thing which I would like to start in collaboration with society, Pakistan Society for Robotics. Agree? Now, the gynecological surgeries all can be done by robotic. There's none which we can say that is not done, so there are various which I've just highlighted. Not only that, one thing which is not there is the infertility surgeries, tubal surgeries and endometriotic surgeries are mentioned here. Hysterectomy, now these are the reviews which have robotic, I've just reviewed the literature and put the endpoints over here. Where they are being done in large numbers, and I will quote the numbers later on, robotic assistance benefits in complex benign hysterectomies. In benign surgeries, with the hysterectomy, yesterday Professor Memuna was talking about the hysterectomy, and everybody, one of the questions was, ये तो बड़ी simple सी थी, आप laparoscopically क्यों नहीं कर सकते? उसमें फायदा है, फायदा तो है, इसमें कोई शक नहीं है. But you learn from the simpler procedures going on to the complex procedures. Your tissue dissections and your perception of tissue depths becomes better and better, and then ultimately you are able to deal with the complex sets. And it has been seen that adhesive, where the uteruses have been amongst adhesions, where pelvic inflammatory disease, and this I'm all quoting because I myself don't have that experience. But complex hysterectomies have been much less chance of converting into open hysterectomies once you have a robot. Because of the previous, not only the ergonomics, but also because the way the instruments can be manipulated. Agreed, sir? So robotic assisted surgery and laparoscopic vaginal and open hysterectomies were reviewed 30,000 cases, and in the robot cohort concluded that less conversion of open hysterectomies, shorter hospital stays, but there was no difference in intraoperative complications. But then these were general, all type of hysterectomies. Agla. Another review showed that there was no significant difference between inpatient in the patient's outcome regarding respiratory, cardiovascular, GI, renal complications. However, in some cases there was increased risk of pneumonia because of the prolonged anesthesia. The estimated blood loss remained less, and operative time in robotic cohort was longer. So this is a question which is still not very clear, but robotic assistance does benefit in less conversion towards open surgeries. Myomas are a big challenge because they are large myomas, and we always have been dealing with them with open laparotomies. Then laparoscopy came, and with laparoscopy, the laparoscopic surgeons, where more sedation was present, they could deal with it, but it took a very, very long time. And with the robotic, we have seen that the ones which we have conducted here, the time is definitely very prolonged because we can't take out the entire myoma as we do it in open surgery, and then there's a lot of blood loss. But there's no comparison between a myomectomy done with minimally invasive laparoscopically or robotically. Blood loss are minimal in both, so both could be compared. But one thing is for certain, where the adhesions will be present, robots definitely have an advantage over the conventional laparoscopy. Sacrocolpopexy, if those who don't know, is where there's a pelvic organ prolapse, and here we hinge the vaginal apex to the anterior, to the sacral anterior longitudinal ligament in the sacrum. So robots have been used here, and laparoscopies have been used here, and therefore the conclusion was that there was less blood loss, longer operative time and anesthesia, shorter hospital stays because patient doesn't have the wound, higher incidence of post-op fever. This was something which was going against the robot. The same number of outcomes and symptomatic failures subsequently when they were reviewed after a year. So robot did not benefit in that way, that it improved the procedure itself, but I suppose that for the surgeon it is more easier to dissect because of the better vision and because of the instruments which without working without a fulcrum. Of course, the cost was high, and some of the patients complained that they had more pain as compared to those who underwent laparoscopically. Agreed? So for sacrocolpoplexy, I think if laparoscopic surgeons are good enough, they probably would have shorter operating times, and therefore they themselves or the patients may not benefit in this particular procedure that much. Okay? Endometriosis is a challenge for all of us because it causes a lot of adhesions. It can occur anywhere in the body and especially in the pelvis. It is like a pelvic inflammatory disease which like jams the entire pelvic organs, and it can grow into the organs, and therefore it is a very, very challenging situation. It can be both superficial, it can be in the ovaries where it is easier to remove, but when it is deep, that means it is growing in an organ like a rectum, then it becomes very difficult. Ugly. So endometriosis, it has been shown there is no great advantage. The study where they have been doing these surgeries in endometriosis, it has shown that there is no extra great advantage when you are extracting the endometriotic patches out of the pelvis. But now laser is doing along with robots, and they are showing that will improve the outcome of the patient. Gynecological oncology also remains a challenge for us, and the traditional approach was always open, especially for endometrial cancers. The gold standard was that you do a laparotomy, you do a staging laparotomy, you look at the omentum, you look at the undersurface of the diaphragm, you take the pelvic washings and everything, and therefore gynecological oncology surgeons were very reluctant to revert to minimally invasive surgeries. But once the studies showed the outcome in early endometrial cancer was the same, then minimally invasive surgeries were adopted too. But whether minimally invasive surgery may lymph node extraction for laparoscopy becomes difficult. But the robot has made it much easier, and this remains for only early stage endometrial cancer. And therefore, once the sentinel nodes are able to, and where you are able to identify the sentinel nodes by, I suppose you put, Dr. Jawad, yes. You put anything for the identification of the sentinel nodes, any dyes during the surgery?
Yes, ICG.
Yeah, ICG does. So we don't have that ICG, but where people are using, कर रहे हैं हम? आप कर रहे हैं? हम नहीं कर रहे. हमें
We work in the same operating room.
Yes.
Actually.
Yeah. So ICG, if it is introduced, so then the dissection becomes really give a benefit to the patient that the lymph node extractions can be done. And despite the higher costs, the main thing is the endometrial patients suffering from endometrial cancers are usually those who are morbidly obese, diabetic, hypertensive, and therefore I think these are the ones who will really, really benefit because of the robotic surgery. Okay? Cervical cancer has a different story. Cervical cancer, it has been shown, in fact, at level 1 research, it was stopped because when minimally invasive surgeries were used in cervical cancer, then at one year they found out that the ones who had minimally invasive surgery, whether it was robot or it was laparoscope, they were not doing well. So this was abandoned. So we are not using minimally invasives, and therefore robot has a limited part to play for treatment of cervical cancers. Okay? So with this, was just to show you that though we are starting onto it, this is our first baby step, we are going to move forward. And ultimately, even if not us, our generations to come may not say that we are 15 years behind, maybe we are 5 years. Thank you.
Thank you.
Thank you, madam, for the beautiful presentation on the robotics in the gynecological procedures. Now I request my next speaker to come to the stage and give her talk, Dr. Rehan Kaur.
बिस्मिल्लाहिर्रहमानिर्रहीम। यहाँ इतने सीनियर बैठे हुए हैं कि मेरे ख्याल में मेरा दिल ही डूब रहा है बात करने से। ठीक है, आई एम द जूनियर मोस्टली। अब इम्पोर्टेंट बात है, यहाँ थोड़ा सा बात स्टार्ट करेंगे ताकि ज़्यादातर लोग मुझे नहीं जानते। ठीक है, वही मैं एक्चुअली सबसे पहली बात तो डॉक्टर एलोदी बैठे हुए हैं, इज़ अ ग्रेट लैप्रोस्कोपिक सर्जन। ठीक, मैं बात स्टार्ट करूँगी लैप्रोस्कोपिक सर्जरी से। एक्चुअली पाकिस्तान में जितना मैं समझती हूँ गायनी में रोल है मिनिमल इन्वेसिव सर्जरी का, किसी और फील्ड में है ही नहीं एक्चुअली। क्योंकि यहाँ पेशेंट डील कर रहे हैं हम, चाहे कोई पेशेंट आपके पास फाइब्राइड के साथ आया है, चाहे कोई पेशेंट इवन सिंपल एक्टोपिक के साथ आ गया है, पेशेंट आपके पास एंडोमेट्रियोसिस के साथ है, पेशेंट PID के साथ है, पेशेंट इज ऑलवेज कंसर्न विद फर्टिलिटी आउटकम। बाकी जगहों पे हम कह रहे हैं जी शॉर्टर स्टे, हॉस्पिटल, पेन, इन सारी चीज़ों का बेनिफिट है, लेकिन यहाँ पेशेंट आपका स्टेज पे अगर उसकी फर्टिलिटी प्रिजर्व नहीं हो रही, लेप्रोटमी लीड्स टू एडियंस, और आइडली लेप्रोटमी इम्पोज कर देती है सेल्फ ऑफ फर्टिलिटी। पेशेंट एक जिसकी एक टॉपिक पे लेप्रोटमी हो जाए, वो मिनिमल इन्वेसिव सर्जरी पे ना आ जाए, तो एक्चुअली वो दैट विल एंड अप इन IVF। पेशेंट की एक सिंपल सिस्ट है, अगर वो लेप्रोटमी पे ऑपरेट हो गई, इफ इट इज़ नॉट ट्रीटेड विद मिनिमल इन्वेसिव सर्जरी दैट विल एंड अप इन IVF। ठीक, यहाँ एक्चुअली मैं समझती हूँ जितनी मिनिमल इन्वेसिव सर्जरी की जरूरत गायनी में है, बाकी किसी स्पेशलिटी में उसको तसव्वुर भी नहीं किया जा सकता, उसके 10% भी नहीं, इतनी ज़्यादा ज़रूरत है। लेकिन पाकिस्तान में यहाँ चूँकि हम रोबोटिक की बात कर रहे हैं, पाकिस्तान में अभी गायनी में लैप्रोस्कोपिक सर्जरी बहुत लैग बिहाइंड है। ठीक, यहाँ लैप्रोस्कोपिक सर्जरी स्टार्ट हुई इन 2008 अंडर मिडल ऑफ डॉक्टर राशिद लतीफ़ खान। डॉक्टर उससे पहले भी कर रहे थे किसी हद तक, उसके अलावा डायग्नोस्टिक प्रोसीजर बड़े अरसे से हो रहे थे मिलती में, लेकिन जो एडवांस लैप्रोस्कोपिक सर्जरी थी उसके लिए सर ने कॉल किया इंडियन सर्जन्स को, वहाँ ये सर्जरी स्टार्ट हुई। उसके बाद डॉक्टर एल की सुपरविजन में ये डॉक्टर यूसुफ और मैं शामिल थे, हमने ये प्रोजेक्ट स्टार्ट किया और वी डिड इट फॉर मैनी ईयर्स, एंड जिसमें कि हमने इंडिया से सर्जन आते थे वो ट्रेन करते थे। देन आफ्टर माई फेलोशिप आई स्टार्टेड लैप्रोस्कोपिक सर्जरी इन डॉक्टर्स हॉस्पिटल एंड मेडिकल सेंटर एंड इन नेशनल हॉस्पिटल एज वेल। नेशनल में इनिशियली मैं अपना हिस्ट्रोस्कोप लेके जाती थी और हिस्ट्रोस्कोपी सिखाती थी। आई एम क्वाइट प्राउड, मुझे खुशी है इस बात की कि मैंने मिलिट्री में बेशुमार सीनियर गायनेकोलॉजिस्ट को ट्रेन किया, डॉक्टर्स हॉस्पिटल में ट्रेन किया, नेशनल हॉस्पिटल में ट्रेन किया। इनिशियली मैं अपना हिस्ट्रोस्कोप लेके आती थी, अपनी वजाइना मैनिपुलेटर नेशनल लेके आती थी, अपना इक्विपमेंट। देन मैडम ने फैसिलिटेट किया, वहाँ हमने सारा कुछ रखवाया। इनिशियली वहाँ ब्लाइंड DNCs होती थी, अब इवन नियरली ऑल गायनेकोलॉजिस्ट कैन डू हिस्ट्रोस्कोपी ओवर देयर। पहले मैं खास तौर पे दोपहर में जाके सिखाती थी हिस्ट्रोस्कोपी, ये पेशेंट्स रखते थे, मैं करती थी, एंड दे डोंट नीड टू कॉल मी राइट नो। उसके बाद स्टार्ट करें इसको प्रेजेंटेशन को। उसके बाद लैप्रोस्कोपिक सर्जरी में थाउजेंड्स प्रोसीजर किए गए। लैप्रोस्कोपिक क्वाइट क्विक इन लैप्रोस्कोपिक सर्जरी। मैडम का ये एक पेशेंट था जिसको हमने रोबोटिक के लिए रखा, वो ऑटोइम्यून इलनेस थी, उसको वेंटिलेशन में प्रॉब्लम आ गई, डैट शुड हैव टू बी कन्वर्टेड इनटू लैप्रोस्कोपिक सर्जरी। आई कैन उसकी इन्फ्लेमेटरी एडियंस भी थी। आई कैन डू लैप्रोस्कोपिक स्टेक्टमी नियरली इन 30-40 मिनट्स। मेरे लिए रिपोर्ट के लिए पेशेंस मेरे लिए सबसे बड़ा चैलेंजिंग था कि मैं सब्र से चले, मैंने कन्वर्ट नहीं करना है इसको लैप्रोस्कोपिक में। दिल तो फौरन ही करता था कि रोबोटिक सर्जरी को छोड़ो और लैप्रोस्कोपिक में कन्वर्ट कर दो और फौरन काम खत्म करो घर चले जाओ, बिकॉज आई हैव स्मॉल किड्स एज वेल। लेकिन मैंने टाइम एक दिन में 3 रोबोटिक गायनी सर्जरीज भी की हैं नेशनल में मैंने, ठीक। नो वी कम हियर इज सम स्लाइड्स फॉर माय जर्नी फ्रॉम लैप्रोस्कोपिक टू रोबोटिक सर्जरी। लैप्रोस्कोपिक प्रोसीजर तकरीबन थाउजेंड्स में की है मैंने, जिसमें स्ट्रोस्कोपिक एंड लैप्रोस्कोपिक all are included. Even laparoscopic vaginoplasties, laparoscopic surgeries with previous 4-5 cesarean sections, laparoscopic surgeries with previous laparotomies. मैं समझती हूँ पाकिस्तान में I am the only gynecologist trained even in surgery and other fields that have been trained from day one from laparoscopic surgery. Immediate after my job, I joined the laparoscopic surgery. And as a second year trainee, I was doing all type of level 4 laparoscopic surgeries. And I have did hardly any abdominal hysterectomy in my life. With previous surgeries, I do laparoscopic surgery, and I am in a school of thought that gynecologists should itself be a surgeon. They should not call general surgeon or urologist if there is a previous 4-5 cesarean surgery and you have to jump to minimally invasive surgery or open surgery, you will call the urologist. यहाँ रोबोटिक के जो हमने केसेस किए हैं वो तकरीबन 38 हैं। ये चलिए आगे। मैं इंटरनेशनल लेवल पे भी काम किया एज अ लेप्रोस्कोपिक सर्जन। आई डिड माई फेलोशिप फ्रॉम बेल्जियम एंटवर्प and with Professor Van Henry. He was the president of European Endoscopic Society. Then he chose me as a trainer and tutor for Flemish trainees. Then I have a training program over there. I run their training program on weekends for workshops of hysteroscopy and laparoscopy. That was in Middelheim Hospital, Stubenberg Hospital, and 3 hospitals of Belgium and France. I stayed over there, and after that next. This is actually, he gave me this, I went over there for fellowship, but they gave me the tutorship, and then after tutorship they certified me for it. Next one. This is the minimal invasive surgery team in Belgium. Next one. Then luckily I am thankful for national hospital team that are involved in robotic surgery project. So general surgery cases, as you know, we are talking from many days, are total 80. Gynecological cases are 38 and urology cases are 9. But पेशेंट्स की काउंसलिंग में मैंने ये देखा, मैं रूटीन में लैप्रोस्कोपिक सर्जरीज कर रही हूँ 40-50 केसेस पर मंथ, लेकिन मैंने काउंसल करते वक्त जब मैंने आई ऑफर रोबोटिक सर्जरी टू एवरी पेशेंट, लेकिन जो मैंने फील किया कि वो पेशेंट विलिंगली एग्री करते थे जो ज़्यादा कॉम्प्लेक्स थे। लाइक ये CS के लिए की गई रोबोटिक सर्जरी, जिस दिन प्रेस कॉन्फ्रेंस नेशनल में आई वॉज बीइंग बिजी इन डूइंग केस ऑफ CS सर्विक्स एंड आई वॉज डूइंग डायसेक्शन ओवर हियर, और उस केस को करते हुए मैंने फील किया कि अगर मैं इसको लैप्रोस्कोपिकली करती तो ये ओपन हो जाता, बिकॉज इसके रोबोटिकली जो एफिशिएंसी ऑफ इक्विपमेंट है, चाहे वो मोनोपोलर है बाइपोलर है, फार बेटर देन लैप्रोस्कोपिक इक्विपमेंट। तो आपका VN आपका बेहतर होता है। स्मॉल से स्मॉल वेसल्स एंड पेडिकल्स को आप कई दफ़ा कैंसर सर्जरी में आपको यूज इतना होता है कि यू हैव टू कन्वर्ट इट, लेकिन इसमें चूंकि आपका कंपैरेटिवली VN बहुत बेटर होता है, मिनिमम से मिनिमम पेडिकल को आप पकड़ सकते हो। इवन मायोमेक्टमीज करते वक्त आप जब अराउंड द मायोमा मूव करते हो, स्मॉल से स्मॉल पेडिकल्स को आप पहले बाइपोलर कर लेते हो बिकॉज ऑफ बेटर VN। लैप्रोस्कोपिकली भी कर सकते हैं, समटाइम वो आउट ऑफ VN हो जाता है लैप्रोस्कोपिक में, और जो बार बार आप कैमरा बाहर निकाल रहे हो, क्लीन कर रहे हो, वो सारे प्रॉब्लम्स रोबोटिक सर्जरी में आमतौर पे यू नीड वंस ओनली टू डिटैच द कैमरा एंड क्लीन इट। चाहे आप 2 आवर्स की सर्जरी कर रहे हो, जो कि एक बहुत ही एडिड बेनिफिट है ना कॉम्प्लेक्स केस। कॉम्प्लेक्स केस में जो ही ब्लीडर आया उसके ऊपर गया, आप साथ ही कैमरे क्लीनिंग में लाके उतना टाइम वेस्ट हो गया, ब्लड लॉस हो गया, ये सारी चीज़ें जो कि एक्चुअली रिपोर्ट हमें फैसिलिटेट सिर्फ नॉट ऑन द, ये नहीं कि हमारे शोल्डर्स पे इफेक्ट आ रहा है सर, वो तो है ही प्रॉब्लम कि भाई आप थक जाते हो। ये सर्जरीज करने के बाद में मैनी टाइम्स आई हैव टू डू फिजियोथेरेपी आफ्टर। मैं नहीं समझती कि अभी मैं कोई इतनी वो हूँ कि मेरे मसल्स फटीग हो जाएं, बट इन स्पाइट ऑफ दैट बिकॉज एक्स्ट्रा नंबर ऑफ केसेस, ठीक है, ये सारा कुछ जो है लैप्रोस्कोपिक सर्जरी इतना एग्जॉस्ट करती है। लेकिन अदर देन कि आप एग्जर्ट नहीं करते, 3 रोबोटिक केसेस करने के बाद भी नेशनल में आई वॉज क्वाइट हैप्पी एंड फ्रेश, एंड आफ्टर डूइंग 3 लैप्रोस्कोपिक 4 लैप्रोस्कोपिक प्रोसीजर आई फील एग्जॉस्टेड। सिर्फ इस वजह से नहीं कि आपको आपका एक्चुअली जो आपके असिस्टेंट है उन सारों की इंटरवेंशन कम है, रोबोट इज योर असिस्टेंट, वो आपको ज़्यादा बेटर फैसिलिटेट कर रहा है एज कि आपका कोई ट्रेनी या आपका कोई मेडिकल ऑफिसर कैमरा पकड़ के खड़ा है, वो आपको उस तरह तंग नहीं कर रहा, तो वो आप एक मेंटल सेटिस्फेक्शन का लेवल भी बहुत ज़्यादा है रोबोटिक सर्जरी। डॉक्टर बड़ा इरिटेट होते थे जो ट्रेनिंग असिस्ट करता था, तो मैंने इन्हें कहा कि यू विल द बेस्ट इन रिपोर्टिंग व्हेन यू विल ज्वाइन, क्योंकि आपकी वो सारी जो इरिटेशन है वो नियरली खत्म हो जानी है, ठीक है। तो रिपोर्टिंग में कुछ और एक्स्ट्रा बेनिफिट्स भी हैं जो कि इस फैसिलिटी की वजह से जो मिनिमाइज हो जाते हैं, जो नज़र भी नहीं आ रहे ना, हम जिनको डिस्कस कर रहे हैं, ठीक। उसके बाद टोटल 38 केसेस, 32 केसेस बाद माई बुक पेशेंट। मैं ये शायद मेंशन ना करती बिकॉज इट इज़ अ टीम वर्क, लेकिन चूंकि मैं जूनियर हूँ तो मैंने कहा ये आपको पता चलना चाहिए कि आई डू इट, ठीक है, दैट्स व्हाई आई मेंशनड इट, ठीक। एंड केस रेशियो देयर वर माइमेक्टमीज, ट्यूबर रिकवरीज, hysterectomies and ovarian cystectomies. And most of the 2 cases of ovarian cystectomies for CA ovary and 2 hysterectomies were for CA endometrium and 1 hysterectomy was for CA cervix. 3 cases were of malignancies and one was with a huge mass of 20 centimeter adnexal mass. And tuber recovery was 3 cases was with where we have tuber adhesions as well as tuber blockage. Tubal cannulation can be better done because of the better vein. We do dual system tubal cannulation with hysteroscopic and laparoscopic assistance. We use 2 cameras at a time, and one we use robotic and the other one we use routine conventional camera, because it's a dual system surgery. You have to use 2 systems at a time for cannulation. And because of better vein, you can better see the guide wire where it is going, inside the lumen tube or outside. And these are the indications. Hysterectomies with previous 4 cesarean section, previous 5 cesarean section was done. Robotically, grade 4 endometriosis, tubal cannulation, pelvic cancer surgeries, myomectomies for broad ligament, excision of adnexal masses, tuber recoveries. But important thing is, no patient was reported with surgical complications. मैं जूनियर भी थी, जाहिर आपको बर्डन फील होता है फॉर रिस्पॉन्सिबिलिटी ऑफ सर्जन, क्योंकि एक प्रोग्राम जब आप इनिशियली रन करते हो आप इस बात में स्टक हो जाते हो कि कोई कॉम्प्लिकेशन हुई इट विल बी रोल बैक, तो यहीं बात खत्म हो जाएगी। नहीं जी, मसला एक पेशेंट आपका जब सीरियस होता है वो हर जगह कहता है जी रिपोर्टिंग नहीं करानी, रिपोर्टिंग नहीं करानी, क्योंकि इसमें तो मुझे ये मसला हुआ, ये मसला हुआ। इस वजह से आप कितने भी एक्सपर्ट क्यों ना हो, यू फील बर्डन, और माइट भी के थोड़ा जूनियर होने का भी आप फील करते हो कि जी शायद ज़्यादा वो काम कर लिया जो नहीं करना चाहिए था, ठीक। तो इस वजह से, लेकिन सारे पेशेंट रूटीन में फर्स्ट पोस्ट ऑफ डे पे विद इन 24 आवर्स एक्सेप्ट 2 or 3 पेशेंट एज पर डिस्चार्ज ऑन सेकेंड और थर्ड पोस्ट ऑफ डे, and nearly in some patients we put the drain and many patients even don't need to put a drain. CS के केसेस में रखा, बाकी किसी में भी। And with in hysterectomy there was no injury to the bladder with previous 4-5 cesarean and no patient needed to be open. हाँ, initially कुछ patients को like ligatures and pedicles को जरूर किया because I was not tuned with bipolar to do uterine pedicles, लेकिन later उसको भी convert करके तो total robotic सर्जरी की, लेकिन myomectomies एंड एंडोमेट्रियोसिस के लिए टोटल रिपोर्टिंग की। उसमें बेसिकली जो एंडोमेट्रियोसिस में है उसमें एडिड बेनिफिट ये है कि एडियंस वहाँ आपने एनाटॉमिकल रिकवरी करनी है पेल्विस की। अगर आप एनाटॉमिकल रिकवरी नहीं करते, पेशेंट कंपैरेटिवली हम कहते हैं आप जितनी मर्जी अच्छी सर्जरी कर लो 30% पेशेंट का पेन रिलीव नहीं होना, बिकॉज इट इज़ अ न्यूरोलॉजिकल इन्वॉल्वमेंट एंड क्रॉनिक इन्फ्लेमेटरी कंडीशन। बट पेशेंट कंसीव जरूर करते हैं आपकी एनाटॉमिकल रिकवरी के बाद, और पेशेंट इतनी कॉम्प्लेक्स इसके साथ आते हैं कि ओपन में आप डिलीनिएट ही नहीं कर सकते एक्चुअली द स्पेस बिटवीन द सिस्ट एंड द हेल्दी ओवरी। इसमें जूमिंग का इतना ज़्यादा है कि मल्टीलोकुलेटेड सिस्ट में, अदरवाइज लैप्रोस्कोपिक सर्जरी में भी मल्टीलोकुलेटेड सिस्ट में कोई ना कोई लोकुलर रह जाता है, लेकिन रिपोर्टिंग में मैंने ये फील किया कि मल्टीलोकुलेटेड सिस्ट में यू कैन सी अ स्मॉल लोकुलाई सेपरेटली और आप उसको रिमूव कर सकते हो और पेशेंट का ज़्यादा बेटर आउटकम होता है। अदरवाइज पेशेंट चाहे 20 सेंटीमीटर मल्टीलोकुलेटेड सिस्ट के साथ आए, पोस्ट ऑपरेटिवली उनका 3 सेंटीमीटर भी आ रहा हो एंडोमेट्रियोमा, वो कहता है आपने हमारी डिजीज नहीं रिमूव, डिजीज इज स्टिल देयर, ठीक। तो दैट्स व्हाई रोबोटिक का ये एडेड बेनिफिट था कि मल्टीलोकुलेटेड में आई फेल्ट मोर फैसिलिटेटेड एज कंपेयर टू लैप्रोस्कोपिक। आगे नेक्स्ट प्लीज। एंडोमेट्रियोसिस एक ऐसी चीज़ है कि जिसमें आपका सबसे ज़्यादा सर्जिकल स्किल्स आपकी एक्चुअली इट इज़ माइक्रो सर्जिकल कि आपने माइन्यूट प्लेन्स में काम करना है सिस्ट को रिमूव करते वक्त। समटाइम हेल्दी ओवरी इज लाइक बहुत थिन वॉल होती है, लेकिन यू हैव टू प्रिजर्व इट फॉर फर्टिलिटी पर्पस। पेशेंट आमतौर पर मैं सब मरीजों का AMH कराती हूँ पहले, एंटी मुलेरियन हार्मोन, दैट इज द मार्कर ऑफ ओवेरियन रिजर्व, ताकि पेशेंट कल को ये ना कह सके डिजीज की वजह से जितना भी कम हुआ है पेशेंट को पहले से ही पता हो कि मेरे ओवेरियन रिजर्व बिफोर द स्टार्ट ऑफ सर्जरी क्या थे। अगर उसका AMH रूटीन में हम कहते हैं 2.5 तक होना चाहिए, अगर उसका बिकॉज ऑफ एंडोमेट्रियोसिस 1.5 था, सक्सेसफुल सर्जरी विल लीड टू AMH आफ्टर सर्जरी 1.5 कि आपने ओवेरियन टिश्यू रिमूव नहीं किया। इफ यू विल रिसेक्ट द ओवेरियन टिश्यू दैट विल फॉल टू 0.6 0.7। तो आई डू ऑफ एवरी पेशेंट AMH बिफोर सर्जरी So I will be sure enough what was the status before surgery, and at the same time to show the patient that your ovaries have not been removed. Till I please. ये एक्चुअली नेशनल हॉस्पिटल का पूरा सेटअप है रोबोटिक सर्जरी के थिएटर का. कंसोल हमें एक कॉर्नर में लगाया हुआ है एंड रोबोटिक आर्म ऑन द अदर साइड एट द एंट्री साइड. And surgeon is performed surgery on the console. Rest of the team is over there, and you can see we use 3 robotic arms. And it was a nulliparous patient that have to need to preserve the fertility, and it was a multiloculated cyst. It was a multiloculated cyst. You can see first. There were adhesions of large intestine. POD was obliterated. And you can see first we will have to do the adhesiolysis. आप cyst को completely resect नहीं कर सकते जब तक कि वो free ना. If it will not be free, तो आपकी cyst वहाँ रह जाएगी. Ovaries का free होना जरूरी है completely before starting the cystectomy. Cystectomy के करने से पहले अगर आप ये को मैं cystectomy start कर दो, बाद में adhesiolysis करूँ, gut loop को separate करूँ, then you can't remove the cyst and you will get the gut injury as well. So first you have to clear the pelvis. And you have to remove all the adhesions. और आप thermal equipment use कर सकते हो, but you will stay on the side of ovary. And you will see whether the ovary is adherent in ovarian fossa से भी आप उसको उठाओगे, because there is a ureter over there. And you will be careful कि आपने retroperitoneal spaces में नहीं जाना. This is the case that was done, and it was done I think on the 20th of August. ये इस multiloculated cyst on the left side. और अपर एक लोकल आया, आई रिमूव दैट. राइट ओवरी में भी स्टेनोमेट्रोसिस था, ओवरी वाज मोबिलाइज्ड एंड नाउ रिमूविंग द cyst on right side. Wherever you feel there is a bleeder, you will BMG at the same time आपके इक्विपमेंट के मैनिपुलेटर के तौर पे भी काम करता है एज अ कोगुलेटर. तो आप वहीं उसको कर लेते हो, नेक्स्ट आप उसके साथ साथ जाते जाते. रोबोटिक आर्म्स पे रिट्रैक्शन इज फार बेटर एज कम्पेयर टू लेप्रोस्कोपिक. सिस्ट में आपने रिट्रैक्शन एंड काउंटर रिट्रैक्शन का मैकेनिज्म यूज करते हैं, तो रोबोटिक आर्म से रिट्रैक्शन इज फार बेटर. समटाइम आपको लगता है कि कुछ ज़्यादा ही लाग, इतनी ज़्यादा कि आपकी अपनी फोर्स कम है, आर्म्स की फोर्स बहुत ज़्यादा है. तो ये रिट्रैक्शन काउंटर रिट्रैक्शन का मैकेनिक सेम है एज ऑन लेप्रोस्कोपिक, बट फोर्स इज अप्लाइड बाय रोबोटिक आर्म एंड यू आर सीइंग दैट सिस्ट इज रिमूव्ड. सरफेस को आप साथ साथ बाइपोलर कर लेते हो, एंड पे आप लीटर्स देख लेते हो. आमतौर पे जो माइल्ड लीटर वो खुद ब खुद भी ऑटोमेटिकली समटाइम्स रिग्रेस कर जाते हैं इफ यू गिव द टाइम. You can do forectomy easily. You will keep the pedicle, just coagulate and cut it. But you have to preserve the ovary and you have to preserve it nearly to total extent, so as patient will conceive after your surgery. Your success is not surgery in guy. Actually, success story will not end up with surgery, that you have done a good surgery. Your success story, your patient should come back with positive pregnancy test. That is the success story. Otherwise patient कहेगा मैंने तो पैसे खर्च कर दिए, मुझे तो कोई फायदा नहीं हुआ, because I come to you for fertility treatment, not for surgery only. This is the second other loculi in a cyst. First I removed the first loculi and it is the second, and it was a big one, you see gradually. And there are peritoneal implants, we do bipolar as well over there. Because mobilization of not the ovaries is necessary, mobilization of the tubes is also mandatory, so as they pick up the ovum, and only a free tube can pick up the ovum from ovary, and patient will lead to pregnancy. Here you can see the cyst. We have to go in a plane between the normal ovary and the cyst wall. Ovary will bleed more. If you will not be in a plane, then you will get more bleeding. And if you will be in a plane, then ovarian tissue will be preserved completely and there will be a minimal bleeding at the same time. Identification of a plane is very important step. Here you can see ovary is now free of cyst. And these patients are put on fertility treatment because fertility outcome is maximum after surgery within first 6 months. I say the patient come back after 6 weeks, we will give you the fertility treatment. we will not left the patient for natural conception. Otherwise, she will come back with recurrent disease after 8 months because it is a progressive illness. जितनी भी अच्छी सही क्यों ना कर लो एंडोमेट्रियोसिस को आप रोक नहीं सकते. Definite treatment is hysterectomy and bilateral salpingo-oophorectomy that we can't offer in a patient who have to preserve the fertility. Next. There was a case who was done when she was 16 years old. She has got road traffic accident and her splenectomy was done. Then she came to me and there was multiple fibroid and she was having menorrhagia. He offered her that we can see the hysteroscopy, we can do hysteroscopy and remove your fibroid and you can go to IVF. But she insisted for laparoscopic surgery and we approached the pelvis after dystolysis of midline adherence from interior abdominal wall because of the previous midline scar. And here you are seeing that there is myomectomy. फाइब्राइड को मैं आमतौर पे वाइन काट डाउन कर लेती हूँ पीसेज में ताकि लेटर मुझे मॉर्सिलेशन की ज़रूरत ना पड़े. ठीक है, into 4, 5, 6 pieces. And we did abortically the cases where we removed 24 pieces of fibroid each 1 to 2 centimeter. We remove 32 and 40 pieces of fibroid later on. And there was a broad ligament. These were broad ligament fibroid and implanted deeply into the uterus. And this is a multiple fibroid into the lateral wall, intramural fibroid approaching to the cavity. And usually I use scissor because it helps to facilitate me, I think, better. Although we can use the L-hook at the same time sometimes works for retraction as well. But to cut in a planes is more proficient with scissor as compared to L-hook. L-hook can cut, but in planes it is difficult to cut with L-hook. But scissor can dig into the planes and cutting is more better with scissor.
But the morcellation was not there, so we did.
We did cut down in pieces intact. फ्री फाइब्रोइड को बाद में पीसेज में कन्वर्ट करना डिफिकल्ट है, इसलिए जब वो इंटैक्ट यूट्रस के अंदर होता है उसी टाइम उसको पीसेज में कन्वर्ट कर लिया जाता है, रिट्रीवल आसान हो जाती है उससे. आई एम मार्किंग इट. अगर टोटली पीस ना भी करें तो उसको मार्क कर लिया जाता है. सम हो किसी ना किसी तरह अगर अटैच भी रहेंगे तो स्मॉल हो जाएगा और आराम से ब्लैक स्पॉट से बाहर आ जाते हैं. The multiple myomas on right side of the uterus, left, anterior, posterior, and all were deep-seated, totally hung up in the uterus. और myomectomy में robotic में efficiency of equipment की वजह से blood loss comparatively कम है. No patient got blood transfusion except that was done for CA cervix. उसकी extensive surgery थी, उसको 2 blood लगे. 2 intraoperatively और later on 1 उसके बाद post operatively. बाकी no blood transfusion in all these 38 cases.
सर वो ओपन सर्जरी में भी इसी तरह पीस मिल निकालते हैं क्या?
ओपन सर्जरी में तो इंटैक्ट निकल जाता ना, रिट्रीवल का इशू नहीं है उसमें. पीस मिल करने से पेशेंट की उसमें कोई डिफरेंस नहीं आएगा. ये इट इज जस्ट फॉर रिट्रीवल.
आइडिया तो मॉर्सिलेशन होगा.
मॉर्सिलेटर लेप्रोस्कोपिकली यूज करते हैं. मॉर्सिलेटर है नहीं नेशनल हॉस्पिटल में ना, मॉर्सिलेटर नहीं है, तो फिर उसको पहले ही मैं काट डाउन कर लेती हूँ ताकि ओपन का रिस्क खत्म हो. जब आप पेडिकल पे जाते हो फिर आप कंपैरेटिवली स्लो हो जाते हो. जो ब्रॉड लिगामेंट फाइब्रोइड है वो बेस पे यूरिटर के साथ जुड़े होते हैं, बेसिक पेडिकल्स के साथ एंड विद द यूट्राइन. कई दफा मैसिव हेमरेज हो जाता है अगर आप पेडिकल्स को आइडेंटिफाई ना करो. ब्रॉड लिगामेंट फाइब्रोइड में एज यू विल गो डाउन यू विल आइडेंटिफाई द वेसल्स. ये इंट्राम्यूरल फाइब्रोइड्स में भी एज यू विल गो डाउन यू विल आइडेंटिफाई द यूट्राइन कैविटी एंडोमेट्रियम. Otherwise, you will remove the uterine cavity and patient will come back with amenorrhea. मरीज कहेगा जबकि सर्जरी उसके बाद मेंसेस नहीं है, आप ये सारे फाइब्रोइड कैविटी को अप्रोच कर रहे हैं एंड यू विल बी एबल टू डिलिनिएट द कैविटी. उसमें एक तरीका ये भी होता है कि हम पहले से मिथिलीन ब्लू इंजेक्ट कर लेते हैं, कैविटी डिलिनिएट हो जाती है. तो आप जो ही कैविटी को अप्रोच करते हो ब्लू कलर टिंट से आपको पता चल जाता है. ज़्यादा प्रॉब्लम उन फाइब्रोइड्स में आता है जो डीजेनरेटिव होते हैं. डीजेनरेटिव फाइब्रोइड्स मिमिक लाइक यूट्राइन कैविटी. उनकी फीलिंग बिल्कुल ऐसी होती है जैसे यूट्राइन कैविटी की होती है at multiple points, and sometimes you might not be able to identify the cavity endometrium separately and that will lead to the distortion of the cavity, amenorrhea and ultimately subfertility. इसलिए आपको यहाँ ये फाइब्रोइड जो ही बेस पे जाता है आप उसको उठा लेते हो, आप उसको कोगुलेट करते हो, कि कैविटी आपकी प्रिजर्व हो जाए। यहाँ ये देखिए, ये फाइब्रोइड को काट डाउन कर रही हूँ मैं पीसेज में। ऑल फाइब्रोइड मिलाकर यूट्रस तकरीबन 3 टाइम्स ग्रेटर साइज के हैं।
ये 10 सेंटीमीटर का।
हाँ, it was multiple and it was on the right side and extended to right broad ligament. ये this is the right adnexus and broad ligament. Now I am suturing it. उसको मैंने नीचे से कोagulate नहीं किया क्योंकि ये वहाँ यूरिटर है एंड यूट्राइन, उसमें मैंने सर्जिसिल को यूज किया, उसको अंदर क्लोज करके उसके बाद सुचर कर दिया ब्रॉड लिगामेंट एंड इट वाज अ रोबोटिक सर्जरी. I put the surgical inside the broad ligament so as to avoid the future hematoma. Sometimes ये तो ये चूंकि क्लोज हो जाना, एक ऑब्लिटेटेड स्पेस है, ड्रेन का कोई बेनिफिट नहीं है कि आपने तो क्लोज कर दी, उसके अंदर आप ड्रेन नहीं रख सकते, वो रूट कर देगी आपके बेसिक जो आगे, इस वजह से आप उसको सर्जिकल रख के उसको मैंने क्लोज कर दिया ताकि फ्यूचर हेमाटोमा भी अवॉइड और उसका कंप्रेशन आ जाएगा उस पर. एंड इट वाज राइट ब्रॉड लिगामेंट फाइब्रोइड एक्चुअली एंड इट वाज 12 सेंटीमीटर. आप पीसेस आप वो लेप्रोस्कोपी के लिए आप एंड ऑफ सर्जरी के बाद पीसेस निकालते हो, कंसोल पे आप एंड ऑफ सर्जरी को अनाउंस कर देते हो, उसके बाद आप लेप्रोस्कोपी के लिए पीसेस निकालते हो. रिपोर्ट में एक जो है, जैसे आप गायनी में आमतौर पे कोई पेशेंट मेरे पास आता है, वो कहता है जी हमने TLH करानी है लेप्रोस्कोपी के लिए, साथ ही हम कोली भी कराना चाह रहे हैं, तो मैं रूटीन में ऐसे करती थी. लेकिन रिपोर्ट में ये रिपोर्टिक लिमिटेशन है कि जब आप लोअर एब्डोमेन में काम कर रहे हो, यू कांट गो इनटू अपर एब्डोमेन फॉर सर्जरी. लाइक एट द सेम टाइम हम लीवर की और गायनाकोलॉजिकल सर्जरी नहीं कर सकते, ठीक है. लेकिन जो लेप्रोस्कोपी के लिए उसमें अपर एब्डोमेन की अप्रोच बेटर है एज कम्पेयर टू रिपोर्टिक. आप 2 प्रोसीजर एट अ टाइम कर सकते हो, लेकिन रिपोर्टिक में आप जब लोअर एब्डोमेन को अप्रोच कर रहे हो, यू कांट अप्रोच द अपर एब्डोमेन. रिट्रीवल भी आप रिपोर्टिक कैमरा से नहीं कर सकते, उसमें आपको डिफिकल्टी आएगी बिकॉज मैनी टाइम्स फाइब्रोइड स्लिप डाउन, हेड एंड डाउन होने के स्लिप डाउन कर जाते हैं और हमें लीवर के ऊपर से जाके मिलते हैं. इस वजह से आपको अपर एब्डोमेन से उनको उठा के तो रिट्रीव करना पड़ता है उन पीसेस को, उन्हें काउंट डाउन कर लिया जाता है और राइट आईलिड रीजन में रखते हैं ताकि वो मिल जाए. अगर ये घूम जाए तो बड़ा टाइम लग जाता है आपको उसको ढूंढने में, इंटेस्टाइन के लूप्स में पड़े होते हैं.
Thank you.
Thank you, Dr. Rana, for such an excellent talk. Now it's lunch break for half an hour. Christian, please introduce yourself and then.
I'm Dr. Senior Fellow in Liver Transplant at TB. Especially from Dr. Saima and Dr. Varis from patient perspective. That by starting the robotic surgery at National Hospital, while doing the benign cases like appendix, hernia or benign gynecological procedures, same results can be achieved with laparoscopically with less. How would you counsel the patient that you have to bear the cost, but the result will be same as that of laparoscopically for the benign procedure?
No, you are right. We started with the robotic appendectomy, so we have to counsel a patient. It is a new technology. We are starting with this technology. Hopefully it will bring a better results. It would have 3D vision, there would be ergonomics would be fine, and you would have less complication. We do anticipate. So we have taken a proper informed consent. That was the first robotic appendectomy, followed by robotic cholecystectomy. So similar version was there. We have to explain everything. It is a new thing and we are going to deal, and it would have a better, fantastic technology, and we would come up with your expectation और वो सारी चीजें. जब हम robotic ventral और incisional लगे ना, तो there are clear advantages, and overall world में भी, अब US में भी देखा तो overall there had been 41% increase in the rate of inguinal and ventral hernias robotically. So then we have a clear edge of saying that it is difficult to suture the mesh upstairs, and it is difficult to deal the things laparoscopically than as compared to. So there we had a quite good evidence. But keeping in mind the same, कल भी मैंने किया था, anecdotal evidence जो अभी तक हमारे पास आया, the patients who have undergone robotic cholecystectomies, inguinal hernias and ventral hernias, they have produced excellent results. They have actually came up with a fantastic result. उनके बहुत अच्छे feedback हैं. बहुत अच्छा है, तो इसलिए we are now confident that we can put that data and we can show that data to the subsequent patients. तो probably we are on the right track so far. With passage of time फिर हमने बीच में pancreatic tumor भी की है, splenectomy भी की है, evacuation of diaphragm भी की है, तो practically we are moving on to, और world over भी ऐसे ही काम शुरू हुआ है. They have started with simple procedures and subsequently they have came to the complex procedures, and probably we are going on the same path, and inshallah we will be having the complex procedure with passage of time.
Your question regarding the mixing the patient, it was, we didn't hide anything. We did say that the laparoscopic outcome is going to be the same as this, we think, but because of the better vision, and this is an advanced form which has improved the laparoscopy, would you like to have an improved form, or would you, because for the improved form you have to pay extra, but if traditional laparoscopically has been done. So luckily, because we are dealing with patients who can pay, we are not dealing with the general population who can't pay. Therefore, cost is not a consideration for some of them. You see, these are those category of patients which go for a normal delivery to US or Canada, and they pay 35,000 to the hospital for that private delivery, or else is it $50,000 for that private. For them, if they are getting a facility here for $5,000, they are happy to do that. So that is a bit of advantage which we have, but we hide nothing. We are very clear about it that this is an improved form. Like for example, hysteroscopy. Let me tell you a very simple. Hysteroscopy is putting in a camera inside the uterus and looking at. It's like an improved form of DNC. So we tell them that the traditional DNC is going to cost you say 50,000, but this one will cost you 75,000, and they are okay with that. So if you just tell them truly what it is the choice has to be there. They are the ones, if they can pay it, fine. If they can't, we just, that is why our cases, number of cases are less.
Just to add, जो डॉक्टर जवाब ने level का बताया ना, तो we are on level 1, तो simple procedure पे फिर level 2 फिर level 3 पे, तो we are going as per डॉक्टर जवाब
जैसे जवाब देता है वैसे हम करते हैं, बिल्कुल
हमारा बेबी स्टेप है छोटा सा